But as you know, for type B dissection, there are areas that are not well seen on TEE, and so the overall sensitivity is lower. This is an important slide because I want you to recognize the fact that patients who have aneurysms that are not very large, 4 to 4.9, have an annual dissection rate of somewhere around 1.6%. The rupture rate is quite low in that group, but the dissection rate is not. And in the IRAD registry, what we've observed is that many patients dissect their aortas when they're relatively small. Look at this. Almost 60% had an aortic diameter less than 5.5. This illustrates the fact that aortic dissection is not necessarily a disease of thoracic aneurysms, and that patients may have a normal or only modestly enlarged aorta and dissect it. The same is true for descending dissection, where you see, look at all of these patients who've dissected an aorta that's less than 4.5 in diameter. The future science needs to help us illuminate these patients because size alone is not going to identify them for us. So how should we treat these patients today? Well, for type A dissection, I want to illustrate the fact that these patients need medical therapy for life. Even if we get them through their surgery, they have a diseased aorta for life, and they need great medical therapy. Surgery, of course, for type A. If the patient's not a candidate, then we may do fenestration of the aorta to connect the pressures in the false and true channel and reduce malperfusion syndromes. We look at the current survival. Operated patients have about a 25% mortality, and non-operated patients, as you know, do very poorly. After discharge from the hospital, patients who've survived have about an 85% 5-year survival currently. How old is too old to operate? Well, this slide illustrates the surgical mortality in different decades and the medical mortality. And what you see for type A dissection after the age of 90, the surgery and medical therapies arm pretty much are equal. And many surgeons will not take a patient beyond 90. And one of my professors taught me there's nothing like heart surgery to help you realize your true age. Now 70 to 80 is a different story. Over the last 15 years, what we've seen in IRAD is that the number of patients who've been denied surgery for type A has steadily been going down. And as that has happened, we've seen a steady fall in the 30-day hospital mortality for type A dissection. Surgeons are taking on more difficult and older individuals in the current era, and this is leading to better outcomes. For type B dissection, uncomplicated, medical therapy is the therapy of choice. If they are uncomplicated but they have a false channel or an aneurysm, consider a stent graft. And if they're complicated, probably stenting if they're a good candidate for that strategy, if not, surgery. If we look at the only randomized trial in type B dissection, the INSTEAD trial looked at medical therapy or stent graft therapy for subacute type B dissection, and no difference at 1 year. The 5-year data is under embargo, but I can tell you that it's interesting. The curves begin to diverge after 2 years, and stent graft therapy appears to have possible benefit for helping those aortic patients who survive with type B dissection. We reported in the IRAD registry that at a year there's no difference between stent graft therapy and medical therapy, but by 2 years we're seeing a divergence, and by 5 years there's a significant difference in mortality in patients who've received a stent graft. So I believe over the next several years we'll see a movement toward additional trials to demonstrate potentially the value of endovascular therapy for at least certain subsets of patients. I want you to consider refractory pain or hypertension to be a complicated dissection. These patients have a more than 4-fold risk of early mortality after their early presentation, and we consider them complicated, and we offer them beyond medical therapy. So the current indications for endovascular treatment: size greater than 5.5 in the distal aorta, symptomatic further dilation, rapid expansion within a year, and the aim of this is to depressurize the false channel and prevent rupture. How to follow these patients: medical treatment for life, great surveillance, and patient education. As you know, the aorta is a complicated structure, a thin intima, a very thick media, and the thin adventitia. We don't know when a patient dissects where the dissection plane is. And if it's way out here, you could see that there's relatively little elastic tissue buttressing that false channel. So we have to be very vigilant, especially early, with follow-up and treatment. We also know that partial thrombosis of the distal channel in type B probably closes off these reentry sites, and you get a blind loop up here and more expansion. And we've shown that those patients with partial thrombosis have a higher risk of death in the first 3 years after they've had acute type B dissection. Here's an example of a physician that I care for who was 53.4 at this juncture. Several years later, he partially thrombosed this, changed his reentry sites, and now his upper aorta is beginning to grow. We'll talk about beta blockers, ACEs and ARBs, statins. I'll leave anticoagulations to the next invitation. We know from studies of Marfan syndrome that beta blockers appear to retard aortic growth in patients who are young with the Marfan syndrome. We also know in randomized trials in vascular type Ehlers-Danlos syndrome that patients who are on beta blockers have better vascular outcomes. And we have non-clinical trial data in patients who've had a type A dissection repair of improved survival out several years. If we look at blood pressure control, our target is less than 120/80. And we know from studies like this one that if that is achieved with beta blockers and other therapies, survival is markedly improved. So beta blockers are the anchor stone of current treatment for aortic dissection, short-term and long-term. Additional therapies with ACE inhibitors or angiotensin receptor blockers is supported by the knowledge that increased TGF-beta signaling is likely the final common pathway affecting metalloproteinase activity, which breaks down this extracellular matrix and the fibers in the aortic wall. ARBs have an effect on this indirectly with ACE and directly with ARBs on the AT1 receptors. So these agents make sense in aortic disease. We have one study, a randomized trial of patients with hypertension, where one group got ARB and one group got non-ARB-based treatment, and there was a very interesting and unexpected improvement in aortic dissection if you're on an angiotensin receptor blocker. Long term, we want to use beta blockers to a heart rate of 60 or less. A great blood pressure, I prefer to add ACE or ARB to the beta blocker. If they have atherosclerosis, statins. We don't know about anticoagulation. And then this is very important. Watch for aneurysm formation at 1, 3, 6, and 12 months after they dissect. Some of these move early, and if you image at 6 months, you miss a chance of rapid expansion and rupture. Educate the patient this is a lifelong disease. They cannot run out of their medicines. You have to tell them that. You know, you have patients come to your clinic, oh yeah, I ran out of my statin 3 months ago, I didn't want to bother you, doc. These patients cannot run out of their antihypertensives, and you have to hammer that home with both the patient and their family. And if they get recurrent symptoms, they've got to go immediately to the hospital. Where's the future? You know, we've been here with clinical data, but the future is genetics and genomics and proteomics and more advanced imaging. We have a huge frontier to cross to get at this. Here's an example of advanced imaging with dynamic MR, looking at helicity of blood flow in the aortic wall. If it's laminar, less pressure. If it's helical, more pressure. And if you have higher helicity, you have more rapid false lumen expansion. So look for very interesting advances in dynamic MR in the next 5 to 10 years that will probably revolutionize the way you and I follow these patients and identify those at particular risk for expansion. Disease is very old. Nothing about it's changed. It's we who change as we learn to recognize what was formerly imperceptible. The IRAD hospitals are shown here. I'm very happy to tell you that Dr. Dan Gillen and Dr. Amit Korach have been involved with IRAD from the beginning, and Hadassah has been a steady contributor to our work. It's wonderful to come to their hometown and present IRAD data. These are the co-collaborators I have at Michigan. This is not my work, but theirs and many more. There's no disease more conducive to clinical humility than aneurysm of the aorta. I want to thank you again for the opportunity to present the data on behalf of the IRAD investigators. Thank you.
Thank you. Thank you very much, Dr. Hiegel. And